This is Chapter 26, The Child with Genital Urinary Dysfunction. And here's just a little review of our renal system. Here's a kidney cut in half. You can see the renal pelvis here. This is where we have issues when we get hydronephrosis. This enlarges, just fills up with urine. Here's our nephron here, and if you remember, the glomerulus is out here in the cortex, and that Lupa-Henle portion comes down here into the pyramid, and then we have all the little collecting tubules that merge into bigger and bigger tubules and eventually dump into the renal pelvis and down into the ureter and then down to the bladder. So we're going to start out with UTIs. UTIs can be recurrent, where somebody who gets them a lot. Persistent, where even though we treat with antibiotics, they're hard to get rid of. Febrile, because some are asymptomatic. So febrile, usually it's moved up, not just in the bladder, not just a cystitis, but is moved up into the kidney to polynephritis. And then urosepsis it's in the urine and also in the bloodstream. And that's our kids under 3 months. They don't get infection in one place. It gets picked up and moved all over, and they develop sepsis, bacteremia, germs in the blood. Whether it started in the urine or it started in the blood and then goes to the urine, doesn't really matter, but it ends up everywhere for them. So urine is supposed to be sterile, but it's a perfect medium for bacterial growth. And as I said, some UTIs are asymptomatic. So sometimes we have to do that urinalysis and culture in order to diagnose it. And the most common germs are things that came from the GI bacteria, the normal bacteria in the GI tract, such as E. coli. So urinary tract infections are very common during childhood. They say 7% of kids have had one, and this is a febrile UTI, by the age of 2. More common in girls than boys because of that short little urethra. It doesn't take very long for germs on the surface. If they irritate the urethra, it's barely any distance to travel from there into the bladder. With boys, we see an increase when they're not circumcised. And there's still controversy about whether circumcision, because it reduces the risk of infection of UTIs during infancy, whether it is beneficial or just a total wash, because the risk of complications from the circumcision is about equal to the risk of increased UTIs from not being circumcised. So American Academy of Pediatrics is pretty they don't really favor one over the other, although their latest recommendations have been that there may be a benefit to circumcising male infants, but that it's not a clear enough benefit to recommend it for all infants. Urinary stasis, and you see this is bold. This is the key factor. This is what makes UTIs happen. Old urine sitting in the bladder. Concentrated urine, so the more dilute it is, the more fluids we're getting in a child, the less chance of a UTI. Over distension of the bladder, so not voiding when they first need to go. Vesicoureteral valve reflux, so the valve between the bladder and the ureters can be in the wrong location or just have an issue, and we'll talk more about that. Compression from constipation or anything that kind of pushes on the bladder, the urethra, or just really any of those structures that stops the normal flow or impedes it. And then anything that causes irritation of the perineum. And that's especially true of little girls because it's such a short distance from there right up into the upper tract. So looking at those contributing factors, we said that short urethra is a problem in girls, so we want to be sure we're teaching parents wipe from front to back, because most of our UTIs are the germs that came from the GI tract, so wipe front to back. And in boys, that means cleaning from the tip down the shaft, and that's going to be especially true in those uncircumcised boys. Urinary stasis. What are we going to teach a child? Do not hold your urine. Go as soon as you need to go. Concentrated urine. We can increase fluids. Distended bladder. Well, how does it get distended? Because they're holding their urine. So again, teach them, do not hold your urine. Go as soon as you need to go. That reflux, we'll talk about it a little more, but one of the issues is over distending the bladder. The valve there doesn't fit correctly, and then you get that reflux happening. So again, do not hold your urine. Go as soon as you need to go. Occasionally there really is a problem with the usually the location of where the valve comes into the bladder or some structural issue with it, and those do need surgery. But most of the time, do not hold your urine is what we want to teach. Constipation, anything that puts pressure on the GI tract can cause problems, so we're going to do what we can to avoid constipation. And for most kids, this is plenty of fluids, vegetables, fruits, up and active, right? That for most of us, that's what we need. And then perineal irritation. And this is more of an issue with girls, but some of the things that cause it is really tight clothing, or in the infant, really tight diapers. So don't try and just use up all those diapers in size 1 or size 2. Give them to a friend and get the next bigger size. So along with that tight clothing is tight underwear. So we want loose cotton underwear. Nylon underwear prevents breathing. You get more of a chance for yeast and things to grow in there. Everything gets irritated. So loose cotton underwear. And then bubble baths or harsh soaps should not be used. And I know kids love bubble baths, but they really do need to be limited, and especially a little girl who's prone to UTIs. Those strong, harsh chemicals in the perineal area will irritate that delicate skin there, and then that predisposes them to UTI. So avoiding harsh soaps and avoiding or at least minimizing bubble baths. So how do we diagnose this? Well, we have to get the urine. An older kid, we're going to do a clean catch urine. So teach them to first clean, start to void, then catch the urine after that. You can't do that in an infant or a small child. So we can put on a urine bag. Very important to clean well and get the adhesive really well. Usually the hardest place to get the adhesive is in that the perineal area right there below, particularly on girls, below the vagina in front of the anus. Make sure it's well cleaned and well sealed there. The problem is it's really easy to get contamination on these. So if nothing is there, if they find no bacteria, we can rule out a UTI with that. But if they do find bacteria, they say that really isn't adequate to diagnose a UTI. You have to get a better specimen, which means doing an in and out catheter or a suprapubic tap. An in and out catheter, just like that clean catch, you're supposed to waste the first few mLs, because those first couple of mLs of urine that are sitting there in the urethra, closest to the exterior, just behind the sphincter, can have some germs in them. But it shouldn't be up into the bladder. So we want to waste those first couple mLs. A suprapubic aspiration, this is done by a physician, and they actually put a needle through right above the pubic symphysis into the bladder. You don't have to worry about those first couple mLs of urine because you're only taking urine from the bladder. And that seems to go back and forth, I would say, of where the pendulum is at the time of which one they're doing. Right now we're doing in and out caths. When I was at the hospital, we were doing a lot of those suprapubic aspirations. The residents would come and do those if we had a positive Urinary bag. Now we're really not doing the U bags at all. We're just going straight to the in and out catheters. So that changes probably with location of where you work, and certainly over time, what's the more common changes. So what are we going to see with the UTI? You know, kids give us vague syndromes, vague symptoms, and it's true. On a baby, they're not going to feed well. An older kid's not going to have much of an appetite. They may vomit. They're not feeding well, so in infants we're going to have poor weight gain. And then we finally get to those symptoms that we're used to with a UTI: urinary frequency, painful voiding. In a child who's potty trained, you're going to see incontinence, right? Because you have that urgency and frequency. So as soon as you got to go bad, and that's going to cause some incontinence. Persistent diaper rash in a baby. Fever, bad odor to the urine, blood or blood-tinged urine, and those are kind of, you've got a bad UTI when you're seeing blood. So one of the things we said contributes to it is this vesicoureteral valve reflux. So what happens is the urine goes from the bladder back up the ureters. So when you're voiding and that squeezing down, if that valve does not shut the way it's supposed to and it's open, as you squeeze the bladder, some urine will go back up the ureter. And then you finish voiding, relax the bladder, that retrograde urine, that urine that went up the ureter, comes back and sits in the bladder again. So now we have old urine, right? We said urinary sepsis is our biggest issue. So now we have that old urine sitting in the bladder again, even though you just voided. So here's a picture of where that is. And you can see if this isn't shutting correctly because our bladder is over distended, it makes it easy for urine to go back up. It should open, let the bladder fill, and then shut. And when you void, nothing's allowed to go back up. The times when surgery is needed, usually it's because this valve is way down here, that it's on the distal part of the bladder instead of, or the inferior portion instead of superior. So moving on to obstructive uropathies, an obstruction that stops the flow is going to make urine back up. And the easiest place for it to back up to is into that renal pelvis, and that's hydronephrosis. That renal pelvis will get very distended and dilated. But when you do that, you're stretching it out, you're increasing the pressure in there, you're going to do some damage. And damage is permanent damage. So obstructions, they can be one side, both sides, partial or complete, and they can happen really anywhere in the urinary tract. And wherever they're at, you're going to get backflow above it. And here's a picture from our textbook of different things. Here's our hydronephrosis, right? That renal pelvis all distended. And here we have polycystic kidneys. So all these little cysts all over the kidneys that are not normal, right? No glomerular filtration happening here. We can get a problem with the ureter, that the urine just can't flow down it for whatever reason. Here's that valve. We can have an issue with the valve. Over on this side, it shows a stricture or stenosis down here, or a bit of scar tissue, a fibrous band that wrapped around it. All of these things are going to prevent flow down, so it's going to back up and keep backing up, right? We can also have issues farther down, at the sphincter, or even a stricture way down here in the urethra. And I think that's a good spot to stop.